Good morning. I am very, very pleased and privileged to join you this morning on this beautiful island. I was here once, only maybe 15 years ago, with my children and grandchildren, and to be back was really a delight and a pleasure. I must confess I was rather impressed with the introduction that occurred, especially the prayer. One of the things Mr. Moritz has told me about is the commitment of this group to home care and caring for the quality of life of patients. And I thought that it was beautifully exemplified, although I speak no Spanish. I hope I understood, but, and basically watching the encouragement of caring and humanity. Medicine does many things, but it does not substitute for caring. And in fact, caring is at least a major secret to wound care. Now, Mr. Morris said that I'm supposed to tell you what I've done, which is a little embarrassing. But anyhow, I began my career as an internal medicine doctor. I spent an extensive period of time doing research. And during that period of time doing research at the National Institutes of Health, I developed a problem in my shoulder, which was fortunately misdiagnosed as amyotrophic lateral sclerosis. At that time I was 26, I had 2 children, and my concerns about, or my interest in neurology disappeared because I was on the neurology service and I was taking care of patients with ALS, which is probably a viral disease, and actually that's probably how I got it. And then went into dermatology. I was fortunate. I continued some research, some of it in Cambridge, England, for 2 years at the University of Cambridge. And then I was the chairman of dermatology at Duke University and then the University of Pennsylvania. After that, I left to be the dean of the medical school at the University of California and the director of their hospital system. So I had a rather large hospital and clinics and healthcare. After which, I went to China for 3 years. My wife and I lived in Beijing, China, where we were advisors to the Minister of Health involved with changing healthcare around. And unlike this gathering today, Chinese healthcare is really focused on the hospital. It's all in the hospital. And there's very little in the way of outpatient care or continuing care. There is no home care. There really is very limited use of nursing homes and assisted living facilities. And then, well, through my career, I've always been interested in wounds. And when I came to Hopkins, I was very fortunate to be given the opportunity to become involved with the founding of the Johns Hopkins Wound Center. And my very, very close, if you will, almost brother, Dr. Zettelman, who is the head of infectious disease and also very much involved in the Wound Center. And so throughout my career, I've been doing wounds. And one of the things I really like about wounds is the fact that we see the patient for a reasonable period of time. We have continuity of care. It's not in and out. Our patients know us. We know them. And one of the remarkable results at Hopkins is that we have an outpatient home care program. Because if you, I didn't put the slide in, but it's a circle. And the amount of time in a circle that the doctor is involved is probably 5 degrees. The vast majority of the time is spent with nurses, WOCNs, and home care and family. And one of the critical issues that we will be addressing today is the importance of involving family, the importance of educating patients, and the importance of dealing with things quickly. All of you have had the experience of dealing with patients with huge gaping holes. Those all began as small lesions. And if we had taken care of them when they occurred, they wouldn't be these enormous, gaping, smelling, uncomfortable, isolating lesions. So in fact, in this group, what is being done is the real approach to quality of care and, in fact, minimizing the cost, which is enormous. Wound care in the United States costs $25 billion. $25 billion. And it's growing 15% per year. It immobilizes, it deconditions, and it isolates patients. They have a terrible quality of life, and it involves the entire family. Because when you take the patient to the hospital, members of the family need to bring them. The patient can do things for themselves, and there is an enormous loss of productivity. So $25 billion is a small, inadequate number because of what happens in the family. And one of the things as a physician is clear that healthy patients rarely get chronic wounds. It's because there's something wrong with the patient that they got a wound. Ulcers are a medical problem, and there are major new technologies to heal wounds. Not only that, but in the healthcare system as it's occurring now, not only is it expensive, but if you don't do it properly, what happens is that it is going to decrease the payment to providers. If a patient gets an ulcer in a U.S. hospital, gets a pressure ulcer, we're going to talk about that, what happens is the hospital doesn't get paid. When the hospital doesn't get paid, when a care facility doesn't get paid, this is a very serious problem for everybody. In the United States also, since I can't speak Spanish and I haven't seen that many billboards, in the United States there are all sorts of billboards and these advertising things with law firms saying, did your family member get an ulcer in the hospital? You know, so that there's huge amounts of litigation. And as you will see, Dr. Zettelman and I did a study for Agency for Healthcare Research and Quality where the number of medicines that are available is huge, and some of them have very, very little evidence to demonstrate that they work. Patients are unhappy, and basically preventing wounds is much easier than treating them. The first step in this, and for many of you this may sound like review, but you must be able to see the wound. The patient comes in, they've got block all over them, dressings, but you need to be able to see the wound. A cardiologist cannot listen to somebody's chest through an overcoat. We bare the chest to put a stethoscope on. But you cannot decide on a wound unless you see it. So this is a critical issue. Where is the border? What does the border look like? Is there a problem in the skin around the ulcer? Does the patient have skin disease which ulcerated as opposed to an ulcer? And is there pain or anesthesia? Very, very critically issue, especially for you in Puerto Rico, where there's such a high incidence of diabetes. And we'll speak a little bit more about that in a moment. And these are the usual categories. The most common cause of wounds in the United States is poor veins and venous insufficiency. There's arterial disease, because the blood can't get down there. And there's insensate ulcers, which are, as you will see, a major issue for diabetes and pressure. So here is a series of venous ulcers. You've all seen venous ulcers, and it's usually on the medial aspect of the ankle. It can be on the lateral aspect. And there's also this odd shape, and it's related to the inability of the veins to carry back the blood in a laminar way. That is, it's not turbulent. And what happens is there are poor valves in the vein, and the blood is going in circular areas, just like when you put water in a sink and watch the water go down. The lower slide, demonstrates to you, we not infrequently see this in people whose veins have been removed for cardiac surgery, do bypasses, and it can be a very, very major problem. But there's something else. Here in the upper, here we go. And if I know what to point at. Doesn't matter. But anyhow, this is one of the problems that we don't see when there are venous ulcers. Point at that. Okay. Yeah. Whoops. Go back ahead. Okay. But in the United States, where we have a very hefty African-American population, this is a patient with sickle cell disease. Not uncommon, very difficult ulcers to treat. And when we think about the fundamental pathology of venous ulcers, not a surprise. Sickle cells mean that their blood forms sickles, and it becomes turbulent. And in fact, the blood flow back from the leg is slow. And this is another one. The ulcer on the leg belongs to the young lady on your right. And besides a Playboy bunny in her belly, or a Playgirl bunny, I'm not sure which, if you look on her abdomen, you will see a very dramatic venous pattern. Do you see all those veins on her abdomen? She has lupus, and she has a lupus anticoagulant. She's a young woman, and what's happened is she's basically clotted the major veins inside her abdomen in the inferior vena cava. So what's the point? Why is he showing us this craziness? because what is apparent is not apparent. When you see a young person who has major league venous disease, where there is a family history of abortion, spontaneous abortion, miscarriages, what we know is that there's a whole group of genetic abnormalities which predispose patients to the development of these thromboses. And when, for example, all of you have heard about the patients or people who go on an airplane and they sit for 3 hours and all of a sudden, boom, they get a thrombosis, a substantial number of them have genetic abnormalities which predispose them to this. So when you see venous ulcer patients in individuals who are young, there's a family history of it, they've thrown pulmonary emboli, be concerned that there's a genetic defect. And there's a mnemonic that we put together which is called stall coagulation, S-T-A-L-L-A-L-L, and coagulation SIG. And that means protein S, there's a thrombin mutation, there's an antithrombin mutation, a Leiden factor, lupus, and protein C. And so this is probably a lot more common than people are aware of, especially if you only have one copy of the gene. And as you know, we only have 2 genes. So if somebody has one copy of the gene, they're 9 times more likely to develop one of these thromboses. If they have both copies, they're 80 times more likely. So, many of these things you know about, and it's clear that you've been educated, so I may basically skip this one because we're going to come back to it. But the critical issue is Dr. Zendelman and I, basically the standard therapy for patients with venous disease is compression. 2-layer, 20 millimeters of mercury compression. No ifs, ands, or buts. 50% of the patients, 40 to 50%, will get better with compression. But it has to be drummed into the patient's head that they need to use these stockings. They need to change them every 6 months because they don't work. They can't put them in the dryer. If you put them in the dryer, they're shot. They have to be applied. People have to use them. And in a sense, it's almost like condoms as a birth control device. If you carry it around and don't take it out of the package, it doesn't work. So what you need to do is giving the patient the stockings is really only the first step. Why don't people use them? A, they don't fit, and B, in older patients, they can't get them on over their heels. So what you do is you get something like heads or even ripped pantyhose, and you put it on the feet so that the stocking slides over the back of the foot. And then you can pull this out. But when you do this, we're trying to control edema. That's what you're doing. So if you control edema, you have to be sure that the arterial supply that's bringing blood to the leg basically is adequate. If you can feel really nice pulse, you're fine. You can feel the pulse on the dorsalis pedis, on the top of the foot, you're okay. If there are questions, then there are tests that we get to basically ensure that that blood supply is fine. If it's really a mess, we use Uniboots, which all of you have used, but they have to be changed at least once or twice a week. And ideally, the pressure should be 30 to 40 millimeters, but we'll settle for 20. And if you do this when it's small, then the patient will heal. And here are the 2B grips that we use. The 2B grip comes in various sizes. It's easily measured, it's disposable, and it's inexpensive. The other way you can do it is with the standard Uniboot. Having patients wrapped with a pressure doesn't work. You've all seen it. The approach to using an ACE bandage is really frequently poor. Now, this is an ulcer which is arterial. It's round. It's sharply circumscribed. It is punched out. It's because the blood supply there did not get through. Simple. And it is very, very sharp and painful. Here's another arterial ulcer. But once again, when people have arterial disease, you can feel good about considering that diagnosis. But one of the things you should do is ask, why do they have arterial disease? And what I'm showing you is an unusual cause for arterial disease as opposed to just a vessel. Diabetes. This is a major, major problem. And I haven't told Mr. Morris that I'm spending his money before this conversation, my lecture today. Basically, we are going to spend his money because what we have are disposable materials which are called filaments. These filaments generate 10 millimeters of mercury. And the Weinstein filament used to be a plastic bar with a filament in it. Now they're disposable. And what happens is that this gives you a pressure of 10 millimeters. You basically use the filament, put it on the cheek, the forehead, the face, so you can feel it. And then, if the patient has diabetic neuropathy, they can't feel it with their foot. They can't feel it on their sole. So what this is telling you is this patient can't feel it. And what I have frequently done with difficult to manage patients is I not only do it with the patient, but also with the caregiver in the home. And I say, you see this filament? And I show them how it works. And the caregiver is watching this, be it a grandmother or a daughter or what have you. And at this point, you have encouraged that individual to be involved in the process, and they understand. Then you use the disposable filament and give it to the caregiver, and you tell them, make sure you do this a couple of times so you understand that the patient can't feel. Now, in a place like this, where sandals and high heels and all sorts of things are worn on the feet, where people are walking around barefoot, is it a surprise that they get traumatized? Of course they do. These people can't feel. They don't know they can't feel. And if we only remember one thing today, in this enormously enriched population of diabetics, is that they have patients with diabetes who are neuropathic, somebody's got to look at their feet at least once a week. If it's a small hole, we can fix it. If it gets to be a huge hole, it's really a bear. Now, what we know is that almost 60% of diabetics get foot ulcers because they can't feel these filaments, and handing them to the caregiver or the patient is important because this is very tangible. We're making them part of your team. And eventually they get the idea. 20% of these individuals have arterial problems, and in fact, so that's 80% of patients with diabetic foot ulcers. 80% of them. And this leads to 86,000 amputations a year, billions of dollars in cost, and when it goes on to amputations, 25% of the patients who get amputated are dead in 5 years. And that's a reflection of their diabetes. It also puts in place the notion that you have to control the diabetes. In a study done in the Wound Center with Dr. Zettelman, Dr. Garza, and myself, we looked at hemoglobin A1C levels. You know, that's a measure of the control, long-term control of diabetes, hemoglobin A1C. There was a positive correlation between the levels of hemoglobin A1C and the frequency of ulcers. It wasn't just diabetes, bad control. Because the higher the hemoglobin A1C, the higher the incidence of neuropathy. And it's once again the whole issue that's involved. So one has to basically deal with diabetic condition. And here is an insensate foot. This patient has got a hole in the sole, and you can see it coming out the other side. Now, I mean, now you've really got your hands full. And here's another one. This being a patient who also had Marfan's syndrome. We'll get into therapy in a moment. Now, when you've got one of these deep holes, and Dr. Zettelman will talk more about this because he's the infectious disease expert, one of the concerns we have is osteomyelitis. Frequently, we see patients with diabetic foot ulcers who do not heal, and basically all sorts of things are done, but they can't do anything about underlying infection in the bone. So that's, I'm not going to get into that, Jonathan will do that. And then pressure ulcers, which is a major issue and one that's preventable to some degree. Other things we see are this, and you have to ask what happened basically before. Was it damaged? And frequently, regrettably, because of where we are, and there's some very complicated surgery done, we will see surgical trauma cause this. Or, in this talk about these staph infections. And this happens. Factitia means that it's self-induced. And this is a diagnosable lesion. Look at the borders of this ulcer. You see it's all angles. This is something, regular ulcers don't have angles. What's going on here is this is self-inflicted. Sometimes, this is an unusual picture because it's a male. It's more frequent in females, and it's used as an attention-getting device. Here's things that we did. This is a patient on two more left. Has contact dermatitis with stuff we put on the ulcer. The patient on the right actually was using Cool Pack. You have to ask. And then there's a whole series of systemic disease, and this monstrosity is a disease I've involved with for over 40 years, hydrogangrenosis, which is a consequence and related to abnormalities in the blood, paraproteins, as well as bowel disease, and primary skin disease. That is things that ulcerate. And here, the striking thing about this picture is if you look at this ulcer, you will see the border is elevated. Do you see how uniformly elevated that border is around there? That's cancer. So what will happen is if somebody has a metastasis, sometimes what will happen is it will ulcerate. So what is our approach? It is true. Debridement is critical by and large for ulcers. Debridement is critical. Nothing can heal with a stinking mess in the middle of an ulcer. You have to get that stuff out of there. Not only that, the first thing I said is you've got to be able to look at it. And most patients, as you know, who come to you will in fact come in with a dressing and all sorts of glock all over. It takes a while to get it cleaned up, so you really have to look. Debridement is often not done properly. It's not done aggressively. And one does have to keep these wounds free of debris. 2, I don't know how many surgeons are in the room right now. Dry lesions don't heal. You know, wet to dry is somewhat barbaric. When you rip the gauze off, it hurts like hell. The patient doesn't like it, and it really doesn't help. So you need to keep things moist. And in fact, it goes back to the first medical publication known, which is the Ebers Papyrus from ancient Egypt in 2500 BC. I'm not making this up. It talks about what you do to encourage wounds to heal, and it basically deals with moisture. Any one of you, would you be rather walking in a desert in Arizona or the Sahara in Africa on the sand at 90 degrees, or would you rather walk on the beach in Puerto Rico? You know, skin cells are not stupid. They'd rather be at the beach. And in fact, this has been shown repeatedly. You cannot get epithelium to move across the wound without moisture. There also is the use of dressings, and basically, as we talked about, compression is critical for all wounds where it is appropriate. Because if you have edema in a wound, even if it's not venous, what will happen is the edema prevents it from healing. Remember, you've got to make sure that there's no problem with the arterial side. And just like the outside, there's 1,000,001 things that we use, whether it's silver or ropes or dressings, and we'll get into that a little bit later. And once again, here's the material. What Dr. Zendelman and I found was that aplograph, which is the reconstituted human skin, and some of the biological tissues really do work in healing. But as you will learn, most of the others there's no evidence for it. And this is how we put apligraph on. It is very, very expensive and should be used only when it is appropriate. And then we use VAX. And all of you may have seen these. These are devices which are clearly working in surgery. There's much less evidence that they work in leg ulcers. Now, so this is the summary list of, you have to know what you're looking at. Somebody has to do a full H&P because you need to know what the associated diseases are. You have to check the veins and the arteries, the diabetes. And if this looks a little bit deep, then make absolutely sure there's no bone involved. And in fact, simple care heals most ulcers. What you do is probably right, but you have to enroll the patient and the patient caregivers in what it is you're doing to ensure that this works. You do need expert opinion. When things don't work, it's not because the patient's not cooperating. Often, it's because we're missing something. I don't know is a perfectly great medical diagnosis because it underlines the fact that, and I write it in my charts, Jonathan will tell you, you know, IVK is all over the place. You know, this isn't behaving correctly. Maybe it's not because the patient's not cooperating, it's maybe because I don't know. So I have to ask again and rethink the problem. And what you are doing with home care and nursing care really does make a major difference. Now, we're going to turn to pressure ulcers. And pressure ulcers are a major issue. They're a huge issue. First of all, if you get a pressure ulcer in a hospital or a nursing home, very bad. Nobody gets paid. And that makes you very unpopular. Second, there is a perception that all pressure ulcers were preventable. Not the case. It's just not the case. And as I said, in the United States, there are billboards. Did your mother go into a nursing home and out she came with a pressure ulcer? You know, call, you know, Science and Kirk and we'll sue everybody. But the point is that sometimes it's not preventable. And Dr. Zendelman and I were at a conference at the National Pressure Ulcer Advisory Panel, and they laid out very specific criteria for non-preventable pressure ulcers. You get pressure ulcers, your health system, everybody involved really gets a black eye. So there is a major realization now that one sometimes can't prevent. How do you prevent pressure ulcers? And you know, you can do this in home care. When you see the patient, you have to consider, is this patient the kind of person who's going to get a pressure ulcer? So it's very critical that there's an initial assessment. And I'm going to show you some of these documents. If the patient is deteriorating in their medical issues, whether it's at home or elsewhere, then you check them every 3 days. You know, you need to do that because when you see the beginnings of a pressure ulcer, you can prevent it. If you can't, if you don't look, nobody's going to know. Document, document, document what you're seeing. Regrettably, I've been involved in all sorts of litigation about pressure ulcers, and always it's the same thing. When did they pick it up? Who had it first? When did it happen? Did they do anything about it? And it requires a clinical team approach. And for patients who are immobile, you have to turn them frequently. Now, you've heard turn every 2 hours if you're in the hospital. The reason it's 2 hours is when somebody came up with this rule in England. It took a nurse 2 hours to go walk around the room. So basically every 2 hours they would, But the point is that they have to be positioned. And there is and needs to be in this setting a group of individuals, which I understand you have, which are really wound-focused people, who understand this very carefully and clearly, so you can take care of this. And those people all need cameras. You wind up in court, having pictures makes an enormous difference. And the terms we use, and the thing that's always mentioned is the Braden scale. It's actually by Braden and Bergstrom. And a score of 17 or less puts the patient at risk if they're over 65. The next major teaching point. If you're at risk for a pressure ulcer, that does not only apply to a bed, it applies to a chair, it applies to sitting. You watch older individuals and they will be sitting for hours, basically in a nursing home, because they're not always in the bed. So that time is critical with regard to basically ensuring that they are protected when they're sitting. And this is a famous Braden sheet, which all of you, I suspect, have seen. And what it does is a barrier. Now, this is standard. But the point is, in home care, you have to understand the principles. If someone can't feel, so the patient has neuropathy or is very ill, they're not going to move. This makes sense. So sensory perception doesn't mean that the patient has neuropathy all over the place. Basically, can they move? Sensory. Second, moisture. Any of you who have done sports on a hot, humid day, play tennis or golf or gardening, on a hot, humid day, you get a blister. On a hot, dry day, you don't get a blister. It's because your skin gets moist and it's easier to tear. So, can the patient move? Or is their skin moist? Activity. Are they able to shift their weight? Can they move that? Can a patient who's just, you've all done it, you've all seen it, a patient who's had crazy hip surgery, their leg is in this direction, the damn cast weighs, 80 pounds or something like that. You can't pick up moving your foot. I mean, is it a surprise you get a heel ulcer? Of course not. So activity, mobility. Can you walk? Can you get off of it? Very critical. Nutrition. What everybody says that, oh, there's no problem with nutrition. You know, she's where he is, you know, a little bit round. Not true at where we are, which is one of the major bariatric surgery programs in the country for weight reduction. These patients, these obese patients, are protein malnourished. They're referred to jokingly as sugar babies. And what you will see is that they have serum albumins and prealbumins that are extremely low. You can't heal on calories alone. And so frequently, especially in individuals who have poor financial resources, they may be protein malnourished. And then friction and shear. And I'm going to show you that now. The second sheet does exactly the same thing as the Brady scale. Microclimate and moisture, spells out mattress. Activity, tissue tolerance, total body weight. And we know now that if somebody is very overweight and you put them on an operating table, the likelihood that they're going to get a pressure ulcer is substantially higher. And there are companies involved with making all sorts of stuff to the operating room because sometimes our surgery is very prolonged. So, total body weight. The R is repositioning. E is edema. S is shear and friction. And whether they've already developed a pressure ulcer. These are a couple terms that you may or may not want to remember, but in fact, are really, the concepts are really critical. Immersion. When we take somebody and put them in a bed, it's what happens to their back and their buttocks, their heels, their legs. But there's also an issue called envelopment. Follow around the sides. What you're seeing is that the bed is surrounding them. It's enveloping them. And this is a much more effective way of dealing with these pressure ulcers. Here is an example of pressure foam showing you how this bed is enveloping the patient. And those are the measures, immersion and envelopment, of mattresses that basically deal with this. And what we're trying to do, at least in the hospital, very uncomfortable cancer patient, for example, is to try and redistribute the pressure. Now, this is friction. It's a great picture. Basically, and the reason I'm showing it here is because if the patient, you'll see the notion that the patient's head is supposed to be under 30 degrees. Under 30 degrees. Because what happens is you begin to slide, and all of the weight begins to fall and tear. So what the friction is about is the abrasion and moisture working together to basically prevent you from putting pressure on. Now, I usually, part of it here. But just think of putting somebody in bed and, in fact, putting their feet up. So let's have them at 45 degrees like this, and then you put their feet up. Where's all the weight? It's all centralized on your behind. So when, for example, you put in supports under an ankle because you don't want to have a heel ulcer, what you're doing is basically folding them up like a clam, and you're changing the weight distribution. So here we see the importance of trying to inhibit getting all the weight in one place. And this brings us to sweat and something that you will observe at home. People who, if they have incontinence, or if it's in a hot, moist area, and it's humid, and all of us, in polite society, we don't talk about where we're sweating, but I mean, it gets pretty moist down there. And if you do that, just think of a garden glove in the summer or a tennis racket on a moist day. So it's really critical to actually think of moisture. That's what, now you're beginning to see what the Braden scale is all about. So, you have to watch. Pressure ulcers are not a problem if you get them early. You have to ensure that you're checking them to make sure they're not getting them. And remember, when you go into the home, if these are problems in the home, you've got to fix them, or at least carry on about the concerns. You have to basically manage moisture, ensure that the potato chips, the salty soup, the fruit soda is limited, and basically enroll, which I suspect you all do, other family members in dealing with a recalcitrant grandmother who said, this is all nonsense. And remember, it's not about beds, it's about beds and chairs. Now, there are certain things that one can do, which are the use of pressure devices. And there are three kinds. One of them is an overlay, which is a pad, a special mattress, or an integrated bed system. What the point to be made here is pressure redistribution devices should serve as adjuncts and not replacement for repositioning. You have to basically tell the patient and their family, damn it, move this way, move that way, move this way. And having in some way, remember I told you about the diabetes with the film, directly talking to the caregiver really helps. Important. Synthetic sheepskins for pressure distribution doesn't do a damn thing. I'll say it again. The sheepskin, it's been proven, sheepskins don't work. What you need are appropriate devices, and one of the most popular is the low air loss. It demonstrates, this slide demonstrates that in multiple studies, these mattresses help, and that if the company or the wound team wants to do it, then it's much better to use the mattresses than the overlays. They last longer, they're more cost effective, and they really are useful. Because if you're dealing with moisture, you want to dry it out. And what a low air loss mattress does is it basically has tiny holes. So the whole back of the patient is dry. If the other thing that you can do, I'll stick that for time, is that you can have a mattress which is moving, which is powered. And what it can be is either a single zone or multiple zones. And what happens in this is that these mattresses go up and down. They're on multiple backwards. So what's going on is the patients, as they're sleeping on them, the mattress is moving. And that is a very sensible way to reposition it. So let's think of this as one of those tubes that your grandchildren or children use when they go to the beach. You know, all the baffles. What's happened is that the motor is moving one baffle up, another one down. So what's happening is the pressure is changing. And then here is the Cadillac, the Mercedes, the Ferrari. And these things cost $50,000. And they're huge, and they're really only and rarely do we at the Wound Center go to this, usually for patients who are paraplegics or something like that, where we're really trying to do that. But the point is, within reason, if you've got somebody who's always soaking wet, you're using low air loss. And if you've got somebody who's really having moving problems, what you do is request one of these active, powered, alternating pressure mattresses. The key to all of this with pressure is early detection of problems. You who are taking care of the patient understand the patient best. You know what the problem is, especially if you go into the home. So you have to basically report the problem. If this is getting to be more of a problem, then you have to have a resource, and that is the wound care team, who will come in and make decisions about beds and what should be done before the problem gets any worse. The critical issue that you provide is how to prevent illness. You're the ones making the difference. You're the patient advocates. And as the caregiver, you have to go to somebody in the house who's your advocate. You know, occasionally a daughter, or it's usually, you will notice these are all either OCNs or physician's assistants, all of whom are the way we prevent and make this problem better. You're the key issue. We can opine, and I guess we'd write the orders. But as all of the women in the audience know, knowing how to handle somebody else is really the most effective way of doing things. And it really involves engaging and involving people and being able to effectively make a change. Thank you very much.
Okay, thank you and buenos dias. to actually tell you a little bit about myself and then what I'm going to talk about. I'm an infectious disease physician and originally from New York. And after finishing my training, I was an academic intelligence service officer at the CDC. Has anybody seen the movie Contagion? Yeah, so it's not as, the people who went with me on outbreaks were not like Kate Blanchett, but we did have a lot of fun. But I was assigned when I went to the CDC to the Sexually Transmitted Diseases Division, and made my initial academic career in gonorrhea. My father said to me, how do you make a living doing gonorrhea? And, in the late 1980s, I set up the surveillance system for antibiotic resistance, and I think many of you have heard about the really terrible antibiotic-resistant gonorrhea that's actually out there now. And I feel like I've been waiting for this baby to hatch for 29 years. So that was my initial career path. I went to Johns Hopkins in 1989 and ran the STD clinics for a number of years, had a long career in sexually transmitted diseases. And then about 7 or 8 years ago, Jerry comes into my office. I'm the head of infectious diseases at Bayview. Jerry comes into my office with a long list of papers and says, what the hell do these cultures mean? These are cultures from patients in the wound center. And we started looking at this, and he seduced me, as an STD doctor, he seduced me into the wound business. And one of the things that we realized that there's no data to guide us, and as an academic enterprise, this is an enormous opportunity in order to try to develop a new field. So I was really very privileged to have been working with Jerry in the Wound Center for the past 8 years. What I'm going to do the rest of the morning, what I'm going to do is talk to you a little, since this is something which I've done with both the nurses and the physicians at our hospitals, give you a sense, talk to you about MRSA, because there's a lot of misconceptions about this, about what it means, how to treat it. Then I'm going to talk to you about our work on the evaluation of the bacteriology of wounds and what that means. And then, assuming we still have some time, Jerry and I will describe to you more details on the 10,066 articles that we looked at to actually evaluate the evidence for venous ulcers. And I think this is very important because the whole issue of evidence basis for treatment is becoming really important. So let's talk a little bit about MRSA. MRSA, really, penicillin resistance, when penicillin was discovered in the late 1930s, all the staff was sensitive to penicillin. In fact, I had an unbelievable patient in the wound center about 7 years ago who was a guy who played football for the University of Pittsburgh in 1943, broke his leg, and developed chronic osteomyelitis with Staph aureus, and had a draining sinus for 60 years, 65 years. And that bug we called it an antique MRSA, staph, because that bug was highly sensitive to penicillin. So the bug that he had was the same bug that he had in 1943. In the late 1950s, there was the beginning of severe penicillin resistance outbreaks with staph related to nurseries. We got Nafcil and Opticil, the new generation of penicillins. But really, MRSA did not, and MRSA, hospital-acquired MRSA was present until starting in the 70s, and certainly when I was in training in the early 1980s, if we had somebody with MRSA, it was usually a hospital-acquired infection. It wasn't that common. However, in the 1990s, MRSA really started taking off, and something called community-acquired MRSA, which is the CA MRSA up top, that's the one which is very common, which is the one that we see. There are a couple of characteristics about it. This is something which is seen probably by all of you Anybody who works in emergency departments, urgent care, this is a boil. Now, for some reason, patients always say it's a spider bite. I'm not sure what it is about spiders, but they always say it's a spider bite. I've had even patients with syphilis say that they got a spider bite, which makes you wonder what the spider was doing, or who was the spider. But I think this is something which is commonly seen, and in fact, it's very clear. This is an abscess, this is a boil, it's a purulent, but notice there's no erythema around it, but certainly you can see all kinds of variations on it. The important fact is, in the United States, including Puerto Rico, 65% of staff which is seen in urgent care settings is MRSA. 65%. So the idea that MRSA, when you hear people say, oh, my relative has MRSA, that I have to put myself into a cocoon, wrap myself in plastic, and walk around the street in a total body condom. That's nonsense. Basically, this is something that we see every day. And in fact, one of the risk factors for MRSA traditionally were being gay, being in jail, injecting drugs, being in the hospital. Yes, that's all true, but most MRSA is seen in people who have absolutely no risk factors at all. So you don't have to impute, you don't have to imply any of these other factors. So it's the most common cause of skin and soft tissue infection in the United States. It's different than the hospital-acquired MRSA because in terms of the genetics, it has something called the SEC-MEC gene, which is a very small gene which actually provides the genetic coding for the resistance. These are usually sensitive to rifampin, doxycycline, and trimethoprim sulfate. So these community-acquired MRSA are usually sensitive to these drugs. 50% is sensitive to clindamycin, which means 50% are not. So don't use clindamycin unless you have susceptibility results, or unless you know the MRSA in your community are sensitive. And there's usually young patients and usually no other risk factors. This is important. Now we see in old patients in the hospital acquired CLABSI, central line bloodstream infections are often MRSA as well. But when we talk about skin and soft tissue acute, we're usually talking about young patients. Now I'm also going to talk about managing MRSA in chronic wounds as well in the second part of the talk, and that's a legitimate issue. This is the doxycycline business. Basically, this is how it's tested for in the lab, and most commercial labs will test for doxy. Now, MRSA can also cause all kinds of terrible, terrible problems. And there's a couple of slides which Jerry showed, which I'll show at the end of the talk. Some of the ones which Jerry skipped over, which he said I'll talk about, I will show you and go into. This is actually this is an interesting patient, which is a once-in-a-lifetime guy. This is a guy who had cervical spinal hardware, which had MRSA infection. Now the problem is if you have a prosthetic joint and you've got prosthetic joint, you have MRSA infection. Usually the solution is to take out the joint. They're very difficult to heal. This guy, you can't take out his cervical spinal hardware because it's supporting his C-spine, and he also had a liver transplant. So, so he was on immunosuppressives. And this guy, what happened was, I didn't know what we were going to do with him, but this one we went way out of the box. We treated him with IV vancomycin and rifampin for 9 months. And actually, he healed. He healed. And I was completely blown away because I know this is like, I thought that we would have to be on suppressive therapy. He completely closed, and that little thing at the end was actually just a small sinus tract which only went down 2 millimeters, and he eventually closed. We stopped therapy because he started developing toxicity, renal problems with vancomycin after 9 months, and problems with rifampin. I threw up my hands and said, oh my God, and I stopped, and eventually he got better. So every once in a while you're lucky. MRSA is all over the world. This is showing you what happens if you get on a jet plane. It turns out there's differences in different parts of the world. It's less in Europe. It's less in the Middle East, but in the Middle East they have enormous problems with extended spectrum gram negatives. and they're usually associated with high levels of antibiotic use. So one of the concepts that I want to transmit to you is that I'm an infectious disease doctor, and I am very, very stingy with antibiotics. In fact, my wife is always upset with me because she has a cold. Can you prescribe a Z-Pack? You know, and say no, and then I get it finally, you know, and I keep on, I try to persist as long as I can. MRSA has also affected football players, professional sports players. This was the St. Louis Rams a number of years ago. This is the New England Journal paper. There was actually a MRSA outbreak in the St. Louis Rams football team. There's been others in some baseball teams. Usually what happens is, usually the most effective way of intervening in this outbreak was some very simple interventions. I'll give you two examples. One is, during the break I went to the restroom. I have never, you know, I know this is healthcare providers, I never saw a line to the sink to wash your hands in the men's room. But there was a very long line to wash, because everybody washed their hands. Everybody. The intervention for this outbreak was to tell them not to share towels. No, seriously, they were in the locker room and the professional sports team, they were sharing towels, they were sharing soap, they were doing all kinds of nonsense, and they actually did that. So this is giving you an example of some of the data. MRSA in emergency departments, skin and soft tissues, this is like a very large network of emergency departments run by the CDC. 65% of subjects who had staphylococcal infections had MRSA, and that was a New England Journal reference. Where is the bug and how do we get it? Many persons are colonized asymptomatically in places such as the nose and skin area. So for example, if you culture everybody's nose in the United States, 10% of people will have staph aureus carriage in their nose, just walking around. We did the STD clinic. I'm still at heart an STD person. We did the STD clinic. We did vaginal, pharyngeal, armpit, and nose cultures in our STD clinic in Baltimore. 40% of people were colonized with staph at one site or other, 15% with MRSA. The issue is, we know that exposure to healthcare, people who have in and out exposure to healthcare, which certainly encompasses a lot of our wound patients who have exposure to the healthcare environment, are colonized with, that increases the risk. Antibiotics is probably one of the most important risks for developing MRSA or being colonized with MRSA, as well as Pseudomonas. People with Pseudomonas, in fact, you don't get Pseudomonas wound infection unless they've had antibiotics. However, only a minority of people, of those who are colonized, actually develop infection. Infection being defined as invasive disease, cellulitis, development of discharge, boils, and so forth. So colonization per se is not a disease entity. And although one has to be careful, we do not recommend under the vast majority of circumstances to treat anybody who's colonized, even people who are immunosuppressed. We just watch them very carefully. Transmission occurs from one person to another via contact, and probably the most important thing is washing your hands and just paying attention to contact precautions. The other area is, this is actually one of the other areas, which is where is community-acquired MRSA? Well, it turns out you can find it all over. If you have teenagers and you have MRSA in the house, you basically try to tell the teenagers to use some common sense, which may be difficult because they're teenagers, not to share towels and so forth. Another interesting source of MRSA is pets. If you culture dogs' mouths and cats' mouths, you find some interesting things, and outbreaks have shown that sometimes the dog is the MRSA carrier. So I think in long-term care facilities, asymptomatic, 20 to 28% of people may be colonized with staph, and patients with skin infections at 60%. So just to review, the established risk factors for MRSA include healthcare exposure. Dialysis patients are over the top. Think about it, they have probably some of the most intense healthcare exposures, antibiotic use, injecting drug users, incarceration, military barracks, close quarters, gay men, HIV, geographic area, having a household member, and contact sports. So contact sports, football, wrestling, lacrosse, all kinds of stuff, soccer, as well. Anytime, usually this relates to, think about what Jerry said, moisture, locker rooms, potential for cross-contamination. Does it matter? Well, it turns out this is looking at the risk of infection after colonization with MRSA compared with MSSA, methicillin-sensitive staph. And it turns out that, and what you see along the line, this is people who were colonized and then developed invasive infection afterwards, followed in long cohort studies. Looks like MRSA compared to regular staph is more invasive. So this is a bug. MRSA is a bug which tends to be more invasive than staph, tends to cause more severe disease than regular staph, and there are a bunch of reasons. So although I said colonization I would not treat, still when people are colonized, they may deserve a little bit more of a closer watch. What do we do? Precautions, surveillance cultures, interventions, treatment, and chlorhexidine. I want to point out probably the most important bullets on this slide are precautions, which again is common sense, common contact precautions, and chlorhexidine. Chlorhexidine is Hibiclens, there's also chlorhexidine wipes, and in the hospital setting it's been very clearly shown that if you bathe patients in an ICU, and more recently data on medical wards, with chlorhexidine wipes every day, that you're going to reduce skin and soft tissue infections due to MRSA and also central line infections. This is something that we also use in patients who have recurrent disease, patients with recurrent boils and things like that. How do you manage them? Well, you can either do chlorhexidine shampoo several times per week, and there's also the more economic version which works just as well, and that's to take half a cup of bleach and put it into the bathtub and have the patient bathe in that. Obviously not their eyes, but if half a cup of bleach in a bathtub, bathing will actually decolonize the skin. Does decolonization work? We'll see that in a second. Is our interventions effective? How do we increase healthcare worker compliance with interventions? This is something which, as a hospital infectious disease person, we're always challenged with. How do we convince our healthcare workers to use precautions? How do we impact? How do we deal? These are open questions. What is the appropriate precautions in long-term care facilities, especially where people live there? What is the appropriate precautions in home care? The answer is there are no good data to guide us. Once a patient is MRSA, are they always MRSA? It turns out there's actually a fairly large amount of people who become, who like lose it, but you have to culture them and follow them. And an interesting question which has been raised for a long time, which is a lot of concern, is if you are a healthcare worker and you are living in a sea of MRSA and you are working with patients who have MRSA, am I going to get it? And the answer is no. It's actually quite interesting. We did a study, a colleague of mine in Hopkins did a study about 10 years ago where they tracked all of the interns, residents, and nurses on the general medicine wards where there was a very high prevalence of MRSA. And the total number of people who became colonized, not even infected, colonized, was maybe 1 or 2%. So basically, if you're not taking antibiotics and you don't have any of the underlying diseases, and you are doing reasonable control precautions, you are not going to get sick. And I think this is important for community education because you hear about, oh, somebody had this terrible necrotizing fasciitis with MRSA and they're going to close the school. And the answer is you don't have to do that. So, what about in patients who have chronic diseases, the types of patients who you'll be seeing day in and day out? This is a study done by Namali Stone, who was at CDC and Emory, who's probably one of the leaders in geriatric infectious disease. This is the Atlanta VA long-term care facility. The MRSA screening prevalence in this nursing home was 60%, 59%. It was associated with prior hospitalization, prior receipt of antibiotics, presence of open wounds, and having had strokes, which is actually interesting. Persistence was associated with bioburden. In other ways, if you actually look at the number of bacteria that are in the quantitated, the bacteria that were in the cultures, and the higher the number of bacteria, the longer you had persistent colonization. So this is stuff which actually, in the context, I think there's no surprises here, except for maybe why does somebody have a stroke be more susceptible to MRSA, but all that makes sense. Contact precautions is a standard of care. We all put on gloves, gowns, and so forth. But actually, the data to show that it actually works more than washing your hands is sketchy. This is like one of the hidden things that nobody in the infectious disease community really talks about. This is like because we tell everybody to do this, and evidence-based, and in fact, there are studies in ICUs in the UK and more recently in the US to show that actually, at least in ICUs, the evidence that contact precautions really makes a difference in terms of infection rates is actually no different. But what I think is happening is that it basically improves the safety culture so that everybody's washing their hands. If everybody washed their hands and did what they were supposed to, I don't think this would be an issue, but I think part of this is actually a way to change culture. What about decolonization? Decolonization, this is actually, for example, as I mentioned, up to 70% of people with staff who are admitted to our hospital, JHPMC, Johns Hopkins Baby Medical Center, are MRSA. So what is this? This is of the people with staff. I mean, not 70% of all admissions, but of the people with staff. It doesn't make sense to decolonize them. It turns out if you decolonize hospital patients, I think I have the slides in here, if you decolonize the patients, what happens is you get a very short-term gain. You get about 70 to 80% decolonization impact at about a month, but after 60 to 70 days, you get recurrence. So decolonization works in a very short time in hospital or long-term care facility patients, but it doesn't persist. The other issues that we have in terms of strategies for MRSA are primary prevention, cohorting, which means that especially as you deal with hospital bed problems, taking patients with MRSA and having them room with other patients with MRSA, which is called cohorting. We discussed decolonization. We also, as you know, there's also a large interest in screening, especially in acute care hospitals. And it turns out screening gives you a lot of information, but does it impact on transmission in the hospital? The answer is probably not. So another thing, this was actually, screening was something where there was a legislative mandate. The legislature, especially in New York, who I think was the first one to do this, said, MRSA is a terrible problem in a hospital. We have to screen everybody coming into the hospital for MRSA. So they passed a law, and that's what they did. Did it make a difference? No. So, and I think, so here's a situation where legislative mandates not based on evidence could be a problem. Here's the decolonization study. Sorry about that. This was the University of Michigan long-term care facilities. And what they did is they did mupirocin, which is Bactroban, in one group and did a control group. There are two facilities. To be enrolled, you had to have MRSA positive on 2 consecutive cultures. They had to not be on antibiotic, and they were randomized either to Bactroban, mupirocin, or placebo, which was just the ointment which is used around peg tubes and really has no antibacterial activity. And they looked at 15-day and 90-day outcomes. Again, the population, they had a lot of MRSA. 30 to 36% of the patients, over a third were persistent staph carriers. 5% were cultured with MRSA. 2/3 had recent hospitalizations, 44% recent antibiotic use, a third had diabetes. No surprises here. I think we're seeing a general theme that chronic disease is probably not a good thing. Clearance was effective for 60 to 90 days. But when recolonization occurred, and they actually took the bugs and they did DNA matches, it was the original bug. So it's not like they got it from somebody else. It's just they never fully, so decolonization is not full eradication. It actually results in you actually put it down, but you don't, and obviously there are some organisms which are in some type of incubating state. So the Cochrane collaboration, which is the large collaboration which actually looks at evidence-based, states that there is insufficient evidence to support the use of topical or systemic therapy for eradicating nasal or extranasal MRSA. There's no superiority of either topical therapy or combination, and potentially problems which, if you do this, you could develop either some toxicity or, more important, antibiotic resistance. Chlorhexidine, which is Hibiclens, same effect from bleach, long-term care, acute hospitals, daily chlorhexidine reduced BSIs, bloodstream infections by over 90%, but did not change pneumonia. And there's similar data for general internal medicine units. So this is actually a good in-hospital type of approach. Interestingly, there hasn't been any studies done in long-term care facilities or in home care. My sense it probably would be the same. In terms of treatment for MRSA, abscesses, incise and drain. If there's no, like the one that we saw at the beginning, if you open it and drain it, you probably don't need antibiotics. There is actually an argument in the infectious disease community whether you need antibiotics, but if it's drained, the cure for pus is drainage. Once the pus is out, you probably don't need antibiotics. Our skin infections, generally we will treat if for example, if there's an abscess near the eye or near a vital structure or in the vulval area, we will treat because obviously we want to protect those sites. Treatment options for MRSA is trimethoprim sulfa is the preferred treatment. Interestingly enough, we see a lot of promotion for linezolid, which is very expensive and tends to cause some side effects, but it doesn't work any better than Bactrim. So if you had a choice between spending $10 or $1,000, the $10 option works just as good. And in fact, most of the new agents are being compared to linezolid because nobody wants to deal with the fact that Bactrim works fine. If they're allergic to Bactrim, then doxycycline may be okay if they don't have active disease. Vancomycin or clindamycin. Clindamycin is also a very good option if they're sensitive. Vancomycin is for systemic infection and when appropriately managed does not have very many side effects. What about cellulitis? And I know you see a lot of cellulitis as well. Cellulitis, most cellulitis in the United States, if there's no abscesses, most cellulitis is actually group A or group B strep. MRSA or staphylococcal cellulitis occurs in patients with abscesses or if there is impaired or if they've had veins removed, like for example cardiac surgery. If cellulitis is symmetrical, if it's presenting symmetrical, and I'm always amazed when I see patients admitted to the hospital and they have hyperpigmentation, they have some swelling of their legs, and they have erythema of the legs, and it's symmetrical right up to the knee, and they have a low-grade fever. Cellulitis as an infection does not act symmetrically, and in fact, we see about 30% of the cases of cellulitis that we see are actually venous stasis disease misdiagnosed as cellulitis. So venous stasis disease, which you guys know about, does not need antibiotics, it needs compression. And in fact, when we actually look at this carefully, we find 30% of the patients don't require cellulitis. In fact, our first line agent for cellulitis is Ansef. then you have to get medical evaluation. And I think I discussed the healthcare workers. So MRSA is here to stay and causes increased morbidity. It's associated with the healthcare environments in the community, especially long-term care facilities and healthcare exposure. The new strains, the community-acquired strains, are aggressive and toxin-producing. The screening interventions are limited utility. Universal precautions are important, and chlorhexidine may have an important role. And wash your hands. Now, if I leave you with more questions about that than answers, then I think I've been successful. As Jerry pointed out, there's a lot that we don't know. There's a lot of people who say that they have the answers to this, but in fact, there are a lot of questions. So what you have at the end, these are some guidelines on MRSA. And what I'll do is I'm going to lead into my next talk, which is on evaluating the infection issues and wounds. I want to give you a background on MRSA before that. But if Eileen's okay, we can take some questions on the MRSA part, because usually there's often questions about this.
¿Alguna pregunta? Antes de pasar a la próxima parte, ¿alguien tiene alguna pregunta que desee hacer? ¿No?
No.
¿Usted qué tiene?
No, todo claro. También. So before I start, this is some of the things, this was actually, let's look at some of these ulcers. This is osteomyelitis, okay? And when you see an ulcer that's not getting better, and especially a pressure ulcer that's not getting better, or somebody has a prior accident that's not getting better, or somebody with prior bone trauma has an ulcer which is not getting better. The key question here is it osteomyelitis? One of the key questions to ask is why is it not healing? And does this patient need wound care, or is there an underlying disease issue? This is from Dr. Lazarus. I'm just going to show you 3 slides. And don't worry about looking through the handouts. I'm just going to throw you these 3 slides from Dr. Lazarus and then go on to the next thing. Osteomyelitis, so evaluation, consideration of osteomyelitis is really important. And it's thinking about it clinically, and does it make sense that this patient could have a bone infection? At that point, once you do go down that pathway, then you can start looking at things like sed rates, CRP. Usually if you're considering that it may have been present for a long period of time, the first step would be to do a regular x-ray, a plain film, which actually takes 2 weeks to develop. If you have a positive plain film, then you make the diagnosis. Or an MRI, which is much more expensive, but is actually the defining type of procedure in this case. These are very important, especially the diabetic feet. They come see you and you have this 5 centimeter radius, 5 centimeter wide ulcer on the bottom of the foot, and you're concerned that it may go into the bone. If you probe to bone on anything, take a probe and stick it in here, that crunch, then you don't have to go any further. That's a diagnosis there. You've made the diagnosis. That patient has osteomyelitis and needs antibiotics, needs an appropriate diagnostic test, which would be bacteria, culture, and IV antibiotics for a long time. If you think somebody has osteomyelitis, they've had this for a while, and this is to the physicians in the audience, they've had this for a while. Do you have to start antibiotics today, now? The answer is no. They've had it for a while. Get the right cultures. If you have a couple of days, get the right cultures, and then start the antibiotics. Because there's nothing more frustrating than seeing somebody who's not healing, and you don't know what the cultures were at the beginning. So the cultures, so basically, I want to kind of frame that issue for you. This is something which we see in Baltimore. Everybody here seen The Wire, the HBO series The Wire. We've got a lot of drug use in Baltimore, IV drug use and IV skin popping. Skin popping and on IV drug, chronic IV use can lead to a lot of chronic ulcer problems, either direct cellulitis, either osteomyelitis because of infection of underlying bone, foreign bodies because needles get retained in there, but most important is chronic venous disease. If you're shooting up into your veins all the time, you screw up the valves, and there's a lot of irritation. So therefore, basically, we see large, tremendous chronic venous ulcers, and remember, as we saw, MRSA is a big issue. And these are mixed bacterial infections, which you can see at the bottom of your feet. Often, if you culture these out, you'll get mixed staph, and because it's the foot, you'll get often some gram-negatives in there. The typical situation for diabetic ulcer is the classic teaching still holds. If the treatment for diabetic ulcer, if it's not infected, is debridement. If we're treating diabetic foot osteomyelitis and we don't have a bone culture, the culture with the organisms that we treat are staph, strep, gram-negatives, and anaerobes, most important being anaerobes. And what I will do in these situations is get a culture just to see whether there's MRSA or not, and that will define whether I need vancomycin or not. If I don't need vancomycin, usually the best outpatient IV regimen is either equinolone if they're sensitive or ertapenem because it's once a day. Ertapenem is a drug which can be done once a day. So. Okay, so with that lead-in, I'm going to show you some data that Jeremy and I have been working on over the past number of years, and then ask you to think about wounds and bacteria in a different way. So, bacteria are important. MRSA was sort of like a test case of this. They overcome host defenses. The clinical signs and symptoms of wound infection are pain, purulence, erythema, swelling, tenderness, warmth, induration, odor, breakdown, friable or hypergranulated wound base. In fact, this is something which you and clinicians can recognize very easily, just as Justice Potter Stewart, who was a famous who was a Supreme Court justice during the 1960s when dealing with pornography. When asked to define pornography, he said, "I can't define it, but I know it when I see it." Clinical infection can be complicated by cellulitis, osteomyelitis, or general sepsis. Many physical signs can be unreliable. And physical signs may be blunted in patients with diabetes. Diabetics may not get fever. Elderly may not get fever, may have a blunted inflammatory response. Patients with arterial disease, they cannot mount an inflammatory response if the white cells can't get there because the blood flow is impaired. But I think in general, using clinical criteria are reasonable. Now, questions that are still out there and important in terms of bacterial disease, in terms of delayed wound healing. Does the presence of bacteria delay wound healing just by the fact that bacteria are there? So, for example, one question which is important, which we've been thinking about in terms of MRSA, presence of MRSA, it may not be causing infection, but does it inhibit wound healing? And this is another concept, so looking at it from the other way, and the answer is we really don't know. What about chronic inflammation? It causes bacteria can alter the host defenses. There are different strains which we know are more likely to be bad actors than others. For example, I showed you MRSA turns out to be more pathogenic than regular staph. That was that table, that chart that I showed you. Wounds can often be polymicrobial, and there's a concept in infectious disease called synergistic infection. Necrotizing fasciitis is a synergistic infection. We have anaerobes, staph, all kinds of other stuff? And is it important to treat everything that's there, or are there bad actors in there which you need to treat? And finally, and this is the most important concept, think about the way we learned about bacteria in school. And think about the way the clinical microbiologist in the laboratory deals with bacteria every day. They deal with it in cultures. In school, we learned about it in cultures, and you had the broth and the cultures, and did all kinds of experiments. When you go into the clinical micro lab, they've got stacks of plates, they've got blood culture analyzers, they've got urine full of bacteria, they've got joint fluid, they've got spinal fluid, they've got all these different things. Think about how we deal with bacteria in terms of our clinical life. How do we deal with bacteria? We deal with bacteria on wounds, embedded in schmutz and mucus. So these are, in the slime that's on top of somebody's, that's in the back of somebody's throat. In a joint infection where it's kind of slime that's on top of the prosthetic device. So the key difference here is in the laboratory you're dealing with free bacteria and they're replicated. However, in matrix form, which is the way most bacteria live, they're actually much different. And that's something called a biofilm. So the planktonic state, which is what the free bacteria call, there's single free living cells in their environment. Biofilm is sessile, or basically sessile means they're stuck, they're anchored down. Aggregated bacteria adherent to a surface. This is usually in a self-secreted polysaccharide matrix. Think about the mucus that's on top of a wound that actually where you have the bacterial load. The importance is actually when you actually look at the microbiology of these bugs, when you have the bugs in these types of matrix biofilms, they're 5 to 10 times more resistant to antibiotics than they are for free floaters. So you wonder why that no matter how much we treat, their bacteria is still there. They tend to be more resistant. They're slower growing. Antibiotics work best when bacteria are reproducing rapidly because they affect the growth cycle. If the bacteria are growing slowly, the antibiotics are not going to work as well. They're better protected for host defenses. This matrix around basically protects it from our white cells, protects it from our cytokines, and in fact they cause more inflammation if the white cells come there as well. And this is what it looks like. So for example, this is a classic biofilm cartoon. And if you look, I'm using the mouse. These are the bacteria are embedded in these. These are polysaccharide matrices. There actually is channels. You actually look at it in the microscope. There's channels where there's communication. And in fact, the bacteria, it turns out the bacteria are even sending chemical signals to one another in terms of regulating their growth, which actually, so if they start to grow too fast, they'll get a signal from another bacteria, hey, we've got the food supply anchored here, you guys got to stop growing because we don't want to run out. And biofilm is something which we see not only in wounds, but all kinds of places. For example, when you go to the dental hygienist to get your teeth cleaned and they're scraping and they're scraping and they're sticking the picks in the bottom of your gums, what are they pulling out? They're pulling out biofilm. In fact, this is where, if you ever look on, and I know many of you if you look on the bottom of a boat and you've got that slime, that's a biofilm. If you haven't cleaned your faucet, if you look at the bottom of your pipes, which probably is not a good idea, you see slime there. That's biofilm. That's different bugs. It's water-associated bugs. But basically, these are things. This is the whole concept. So it's not just limited to this. And we see this in a variety of human diseases besides wounds. Cystic fibrosis is another one. But also, if you pull out a central line catheter, if you pull out a Foley, that's been in there for 2 months, and you have all of this crust and incrustations and mucus and stuff like that on the Foley. And that's all biofilm. There's bacteria embedded in polysaccharide there. And that will never be treated with antibiotics effectively because they just can't get in there. So Dr. Lazarus and I decided to figure out, when he came to me and said, what the hell do all these cultures mean? We decided to try to figure it out. And what we did is we decided to start doing careful cultures of wounds. Now, many of you who learned to do wound swabs, and we actually have changed our protocol. We do a curette from the advancing edge of the wound using 10 to 20 milligrams of tissue. And what we did was we did culture. We also did genetic studies using PCR, which is rapid genetic testing. We also did something called metagenomics, which is actually where we take our tissue sample and send it to a colleague of ours at the University of Maryland, where they ran the full bacterial sequencing on the sample to see what's in there. So it's not just culture, but it's do the sequencing to find the DNA of every bacteria that's in the culture. And we looked at 41 wounds, of which 40% were neuropathic, 20% were pressured, 15% were venous ulcers, and so forth. And this is the procedure. You can see that's the sample that we get. We can do all the studies that I mentioned from that 20 milligram curette sample. So, many of you have seen that you get results from the lab, qualitative, which are not present, few, moderate, heavy. How many of you get samples from the lab where it says moderate, heavy, few on the lab reports? It's something which is seen very commonly. I'm going to show you something which is going to maybe change the way you approach this. We actually took our samples and actually counted the bacteria that were in the sample, in the acute sample that we had. And what we find here is if you look at, this is actually quantitative results to the log 10. So this is 10 to the 7th. This is 10 to the 5th. There is a rule that's out that says a wound has 10 to the 5th bacteria or more, it's considered infected. It turns out that's based on complete nonsense. Don't pay attention to it. If you look here, you see when the qualitative results said few, when it said moderate, when it said heavy, there was basically no difference in the actual number of bugs that were there. When it says of qualitative results, few, moderate, heavy, have no relationship to where actually the results when you actually count the bacteria that's in the sample. And there's a number of reasons why this may happen, and I'm not going to get into them here, but it's not that the lab is misleading you, it's just basically the technique really has a problem. They don't correlate with quantitative results. When we looked at our wounds, and this is a hospital clinic, so we have a referral clinic, people who've been exposed to lots of healthcare and so forth. These are the species that we had in our wounds. 45% had MRSA, about 25% had Pseudomonas and Group B strep. Group B strep, who gets Group B strep? Diabetics and the elderly. Our patient population is diabetic and elderly, no surprise. And then you get into a whole bunch of the other types of stuff that you see, which is regular staph, E. coli, Prevotella, Acinetobacter, Morganella, so a variety of gram-negative anaerobes and so forth. What about if you culture at different parts of the wound? So we did a second study to say, well, sometimes you've got these big wounds. What if we culture the edge? What if we culture the middle? Does it make any difference? And it turns out, all the time, the wounds, the cultures from the rim were the same as from the center. So basically, it doesn't matter where you do it. I would just pick a place where it doesn't. You don't want to do with mucus. You want to get some nice red tissue. And 24 and 25 times, the rim center pairs had bacterial loads within 2 logs of each other. So, suggesting that basically these are similar results. Now, what happens when you start doing the genetics on these bacteria and recognize that only 1% of the bacteria that we know are actually culturable using the culture techniques? The techniques that we use to culture were invented by Louis Pasteur in the 1860s. So what happens when we start doing newer techniques? And we also know that anaerobes are very difficult to culture. So what we found is, although our cultures showed that 3 different bacterial species were present in a wound. When you actually do the genomics, we actually found an average of 17 different bacteria in wounds, which makes sense because the wound is open to the environment, it's open to water, there's all kinds of stuff that's out there. Our wounds, we do not live in a sterile environment, we've got stuff all over ourselves. So metagenomic, and this is also an example of how the wounds, remember I talked to you about the biofilm and how they range? If you actually do immunofluorescence on staining, this is actually from the biopsy from an actual wound. This is a wound that Jerry biopsied. And you see here you've got a bacteria, you've got a rod, and here you see you have a coccus here. And see how it's embedded in the background matrix? This is actually the polysaccharide matrix. There's no way you can deliver antibiotics to that particular place. So really this highlights again the importance of debridement in managing these wounds and getting this material off. This is another example of staph. So the conclusions are that chronic wounds are extremely variable. The bacteria flora is very complex. The microbiome, the bacteriology of wounds is actually much different than that which we would see on our normal skin. On our skin we have staph and strep and a whole bunch of other bacteria which are, but it's not the same that you see in chronic wounds. So this is a pathological state. Bacteria and wounds are arranged in highly organized biofilms. So how do we make sense of the bacteria, the wounds, and how do we approach management? Should we treat with antibiotics, as some have suggested, long and strong? This is actually a direct quote from a lecture which I attended. Or do they need antibiotics at all? You cannot get rid of the colonization. So the fact that a wound is colonized does not mean that it needs antibiotics. The fact that the wound is colonized means it needs good wound care. Good wound care is not antibiotics. Good wound care is debridement, offloading, compression, dressing, as you know. So I'm going to show you the genomics and how complicated these are. They actually detect the DNA of the bacteria. And the bacteria have a 16S ribosome element, which is over here. And I'm not a geneticist either, but basically, let me just point out that this region in the RNA gene is unique to bacteria. And the way you do this is you take your sample, you actually hybridize, you look for that particular region, then anything attached to that is going to be a bacterial DNA sequence. And then you do a sequencing, and the current instruments can now do millions and millions of sequences off of a sample our size. And you match it to a library of all the DNA that's ever been found, which is actually maintained by the NIH. It actually sounds really complicated, but believe it or not, it's actually, and when we started, it was incredibly complicated. When we started to do these samples, it would be about $10,000 per sample if you want to do the whole thing. That's now gone down to about $500. And this is becoming like computer chips. As every year goes on, it's actually decreasing in price. And I think this is something which we're going to see more and more of. This is an example of how the sequencing system works. And basically, metagenomics uses a high-throughput sequencing to identify all bacterial genomes in a sample. Probably more important than having a laboratory is having a computer geek who can help you figure out all the information which comes out at the other end. It's a research tool only. Some people have proposed this as a clinical management tool. I would argue it's a research tool only because we're still trying to figure out how to interpret the data. I will also posit, and I'll show you some examples. Antibiotics are not benign. So somebody has a wound that's not getting better. I think basically, do we give them antibiotics? If we give them antibiotics, we can make the wound more, we can give them resistant bugs. We can induce MRSA. We can induce Pseudomonas. Antibiotics can be costly. So those of you who prescribed antibiotics or bought antibiotics know that they can be very expensive. Especially in people who are elderly, chronic diseases, diabetic, multiple morbidities. If you give them antibiotics, you put them at increased risk to C. diff. And there's nothing worse than having a sacral ulcer with somebody with C. diff. We've all dealt with it. It's not pretty. And if you give somebody IV antibiotics for a prolonged period of time, you have a PICC line and its associated complications. So I think I will leave you here with the conclusion that bacterial genomic technologies may be highly pertinent to numerous skin illnesses, and they can help us understand the pathophysiology of the skin. One of the things, I'm an STD person. One of the things that I went to Jerry after we started looking at our chronic wounds was that some of our patients with chronic wounds, the bacteria in the chronic wounds are the same, when you look at it by sequencing, are the same that you see in a genital syndrome called bacterial vaginosis. BV, bacterial vaginosis, which is chronic vaginitis, and it's actually, I look at this as a generalized concept of anaerobic colonization, anaerobic infection. The role of microorganisms in delayed wound healing is unclear, but should be, I think it's an area where it needs to be investigated. The use of antibiotics may be profoundly altered, but I want to urge you to really think very carefully about antibiotic use and its appropriateness. And one of the things which I tell my residents when thinking about antibiotic use is there's an old advertisement. I don't have a picture of it because I haven't found a good one. There's an old advertisement which was on the New York City subways when I was a kid for the United Negro College Fund, which said, "A mind is a terrible thing to waste." So mind, which in other words says think. So what I'm kind of urging you to do is when using antibiotics, think about what the objectives are, think about what the cost-benefit equation is, and think about what you're actually doing, and then make a rational decision, rational therapeutic decision. So I will leave you on that. Before we talk about the evidence-based review, be happy to take any other questions.